Hello, everyone. Welcome to our bi-monthly resident in-service on spinal cord injury-related topics. This month, Dr. Peter Spurrell is going to be discussing non-pharmacologic management of spasticity. So with that, I'll let him take it away.
Great. Thanks, Dr. Abramoff. Good afternoon, everybody. So today I'll be going over just some general principles surrounding spasticity. I'll briefly mention some pharmacologic management options, and then spend the majority of my talk going over some non-pharmacologic options for management in the long term. So what is spasticity? So it is a motor disorder characterized by velocity-dependent increase in tonic stretch reflexes with associated hyperreflexia resulting from hyperexcitability of the stretch reflex. It can involve single or multiple limbs, can be unilateral or bilateral, can also have truncal spasticity. And in general, the symptoms, present as an increase in muscle tone, overactive reflexes, as well as some involuntary movements that can include spasm or clonus, and in some cases pain as well, which can be quite severe, leading to decreased functional abilities, in some cases delayed motor development, sexual dysfunction, contractures, as well as bone and joint deformities. So we can see it in spinal cord injury patients, as well as stroke patients, which is probably the most common, multiple sclerosis, TBI, transverse myelitis in rare cases, in kids, cerebral palsy, maybe MOGAD patients as well. And in spinal cord injury, typically obviously caused by dysfunction in the spinal cord and the corticospinal tracts. And not just for patients, this also is an important issue to manage for caregivers, because it can be extremely difficult to take care of people with severe contractures and spasticity, in terms of keeping good hygiene for them in the event that they were maybe clenching fists, and preventing skin breakdown. So it's important to manage this appropriately and to start treatment early. These are just some examples of spasticity in the upper extremity. So the clenched fist I was kind of touching on before. If someone has like a contracted fist like this, can lead to skin breakdown and moisture damage in that area. Can be very difficult to range that area, and can lead to infection, which can then in turn lead to worsening spasticity, which I'll get into. And here are just some examples of spasticity in the lower extremities. So we can see the flexed toe on the bottom right, the equinovarus foot as well, which is one I've seen before. And we'll just keep chugging along. This is how spasticity can be graded. It's an objective measure of the modified Ashworth scale. There are some other tools that are used to kind of grade it, but this is one I've seen used most commonly. So it's graded from 0 to 4, 0 being no increase in muscle tone, a 1 being a slight increase in muscle tone manifested by a catch and release, or by minimal resistance at the end of range of motion, a 1 plus being the same, but there being minimal resistance throughout the less than half of range of motion, and then a 2 being a more marked increase in tone, 3 being considerable with passive movement being difficult, and then 4 being having the affected limb being in rigid flexion or extension. Just to briefly touch on some potential triggers of spasticity, depression, stress, anxiety can be causes, as well as insomnia or fatigue. Pain certainly can trigger spasticity. Usually it's a sign of underlying infection, whether that's a UTI or some sort of pulmonary infection, or perhaps constipation, urinary retention. Could be a sign of a pressure injury, whether that's sacral or related to ill-fitted orthotics. And these are just some of many potential triggers for spasticity. Another thing I wanted to mention too is that spasticity in some instances can be beneficial to the patients, and it's while we do typically treat it non-pharmacologically with stretching and things like that, regardless, there are definitely some advantages to having spasticity in some instances. For example, can help with some activities like wheelchair transfer. Sometimes having controlled reflex spasms can help with standing and grasping. And the fact that the muscles are hypertonic when they're spastic like that does prevent atrophy and bone density loss. Overall, there is a reduction in DVT development because the metabolic requirements of the spastic muscle improves blood circulation. And ultimately, like I mentioned before, can be a warning sign that perhaps the patient may be developing some sort of infection or may have something else medically going on that warrants further investigation. The cons being mainly that stiff muscles definitely can hinder other activities, especially in kind of like the occupational therapy space in terms of like getting dressed, putting on a shirt, brushing teeth, doing fine motor skills, especially with the upper extremity. Also can lead to instability falls, which can lead to other injuries down the line. In severe cases, that can be extremely painful. And you really want to try to prevent contractures from happening because at that point they become quite difficult to manage and can be hard to reverse at that point. So treatment goals in general to improve position, mobility, pain, prevent contractures, ease the burden of care. And in general, a multimodal approach is employed involving non-pharmacologic and pharmacologic management tools. In severe end-stage cases, surgical options exist as well, which I won't really touch on today, but just something to be aware of. So this is just briefly to go over just some of the more commonly used medications for spasticity that I've seen so far in my training. So it includes baclofen, which is a GABA B agonist. Typical starting dose is like 5 milligrams TID, can increase every 3 days as needed. It's particularly good for flexor spasms. Some of the, and with many of these medications too, there are a considerable amount of side effects worth considering before starting somebody on them, and typically require close monitoring. So in regards to baclofen, abrupt withdrawal symptom, if the medication were abruptly stopped, withdrawal symptoms are pretty common, can manifest as worsened spasticity, itchiness, a change in mood, and in some cases fever, tachycardia, even seizures. But there is also an intrathecal option for baclofen that we are all pretty much aware about. And that can be a great option to kind of decrease the systemic side effects that are seen with oral baclofen. Benzodiazepines, probably less commonly used, I would say. GABA A agonists, seen Valium used in the past. Obviously sedation, pretty common side effect with benzos, as well as withdrawal. Next would be tizanidine, which is a centrally acting alpha-2 agonist. Reduces tone and spasm frequency. Starting dose is 2 milligrams nightly. You can increase by 2 milligrams per day every 1 to 4 days. It is renally cleared, as is baclofen. So do use caution in chronic kidney disease patients in terms of dosing. And because it's an alpha-2 agonist, can also cause hypotension and sedation. And then dantrolene is the last one real quick here, interferes with the excitation, contraction, coupling complex, typically start at a dose of 25 milligrams TID, and can increase weekly to max dose as needed, max dose being 100 milligrams, I believe 4 times a day. This carries a risk of fulminant liver failure, requires monitoring of LFTs periodically. And those are some of the more commonly used oral medications. There are also injections like Botox and phenol blocks, but I'll save that for another talk. So getting into non-pharmacologic management now, first thing I'll talk about here is stretching. So stretching, commonly employed immediately after spasticity develops. It's a low risk, low cost intervention, and increases muscle spindle sensitivity, which combats muscle shortening, which is implicated in spasticity with muscle overactivity. And in terms of its benefits, they are short-lived, so typically must be done multiple times per day. Like on PM&R rotations in med school, we used to kind of see some of the brain injury patients I had with spasticity would kind of make multiple trips a day just to kind of range of motion them, and definitely not uncommon. Typically, it's taught to patients and caregivers as part of a home exercise program that they can continue at home. And stretching can, include not just passive and active range of motion, but also postural management and other strengthening exercises. So like the use of standing frames to improve like extension of legs and trunk muscles. Lying prone in some instances can improve the extension of leg muscles as well. In general, it's not very well studied nor validated in the literature that I've reviewed. Most of the studies I read, there was just highly variable patient populations and study designs. Overall, there's low quality evidence to support the use of stretching, but again, because of the low risk and low cost to doing it, it is commonly used in conjunction with other therapies. So definitely something that I think should be studied a little bit more focused in some of our spinal cord injury patients, and certainly, is not something that I think is causing much harm, so is still commonly used despite data not really supporting it strongly. Next would be splinting and serial casting. I'll kind of talk about both. So in splinting, provides a stretch kind of over a more prolonged period compared with manual stretching. Generally functions to change reflexive activity, reduce the stretch reflex. And then you can kind of elevate that to serial casting if an individual has evidence of contracture, or maybe at severe risk of contractures related to their spasticity. Seems to be most commonly studied in stroke patients, particularly in the upper extremity, from what I've seen. Again, very low risk intervention, and very commonly employed in patients with C-spine injuries. And in general, I've also read a few papers about people being casted, having the cast applied after a Botox injection to kind of help enhance the effects of Botox, which I thought was interesting. Next topic I have here to talk about is functional electrical stimulation. So this combines neuromuscular electric stim with repetitive passive rhythmic movements, sending low-level electrical impulses to muscles in the legs and arms. Typically used about an hour a day, 3 to 4 days a week. A few of the different modalities I read about were this upper and lower limb cycling, as well as the use of Bioness. Bioness being like these forearm, ankle, thigh, and cuffs are applied, which kind of allow the arm and leg to move appropriately during a specific functional activity, whether that's walking on uneven surfaces, grasping, reaching, or pinching. And then in regards to the upper and lower limb cycling, this was something that I read a systematic review in regards to this, and seems to show that it improves at least lower body muscle health of adults with spinal cord injury, may increase power and aerobic fitness over time. In regards to the systematic review I reviewed, generally a lot of the studies had small sample sizes. There wasn't really a standardized approach to the treatment and the intervention. So I think would benefit from having more research in that regard to investigate that further. Next is neuromuscular e-stim, which delivers a train of interrupted pulses that stimulate axonal terminals, results in muscle contraction to strengthen spastic muscles. Not very well studied in spinal cord injury, more commonly in the stroke population. There was a systematic review of clinical trials back from 2019 that suggested that when compared to placebo, at least, was associated with a reduction in spasticity and improvement in range of motion. I just include this because I know I've seen this used as well for some patients, not necessarily for spasticity, but I think it's something that could be worth learning more about as it applies to that. Next, repetitive transcranial magnetic stim. This technique is typically or historically has been used to treat treatment-resistant depression. It involves using an electromagnetic coil, which is placed on the scalp. This delivers repeated magnetic pulses to cortical tissue. And it's used to modulate cortical excitability and induce remote effects on the excitability of spinal circuits. I read one study that demonstrated that the use of this in terms of activating the leg motor cortex can actually be beneficial in spasticity management by enhancing corticospinal tract excitability and reducing the H reflex. It's a non-invasive therapy that's well tolerated. This, I think, could be a promising tool for treatment of spasticity for various pathologic conditions outside of spinal cord injury as well. And I think there is still room for further investigation to test, whether different stimulation protocols, whether or not using different frequencies of stimulation, or stimulating alternative cortical sites in the motor cortex may induce greater benefit. All right. Next, I'll talk briefly about shockwave therapy, which most of you may know, first introduced to help manage nephrolithiasis. This is also quite non-invasive. It involves using a sequence of sonic pulses characterized by high peaks and rapid increase in pressure, which act through direct modulation of muscle tissue. It's thought to break the functional link between actin and myosin, which reduces the rigidity of connective tissue. I did review a randomized control trial from 2018 that compared this to Botox use in stroke patients with spasticity. And both groups saw statistically significant improvement in modified Ashworth scores at 4 weeks. And there was no statistical difference between groups, suggesting that this may be a decent alternative and less invasive alternative for people who've at least had strokes and are suffering from spasticity there. And I think that's all I have.
Any questions? From the audience. So would you recommend, well, go ahead, Erica.
Hey, Pete, thanks. That was a good lecture. Thank you. Some feedback. Just quick question. I was looking at a case study and someone was getting a TENS unit for spasticity in the leg. And they ended up having neuropathy after it because they were using like a really high amount of electricity, essentially. Did you come across that at all?
You're muted, Peter.
No, I did not come across that case report, no, but would be happy to read about it if you could share it with me.
Any other questions? So, Peter, if you have a patient with a spinal cord injury, and they have some spasticity, or you're seeing them shortly after their spinal cord injury before their tone kicks in, what are you going to tell them? What are you going to tell them about stretching? What are you going to tell them about spasticity management? How will you approach it, do you think, clinically?
And this is in a patient who we suspect is developing spasticity, you're saying?
No, this is even before they're in spinal shock, but maybe they're starting to emerge from spinal shock.
Well, in general, I think I would, introduce the topic, the concept of spasticity, and explain to them what it may entail in terms of determining if they're spastic. Doing range of motion, ranging them in their upper and lower extremities to see if they may have an increase in muscle tone, or checking their reflexes to see if they're hyperactive, checking them for clonus, and if they don't have any evidence of it, then may try to introduce the definition of it to them and make sure they understand things to look out for. Probably start doing range of motion exercises immediately, or as soon as the patient can tolerate them, and be on the lookout for any development of spasm or contracture.
What would you do range of motion exercise-wise? What would you tell them to do?
I think, you could do a combination of passive and active exercises. You can passively like flex and extend their, like do passive elbow flexion and extension. Want to focus on both proximal and distal lower extremity and upper extremity muscles. And if they were showing signs of developing spasticity, may consider using some medication on top of that. If they're
would there be other modalities that you would routinely recommend?
Probably some combination of stretching, and if it were an upper extremity spastic joint, I would probably recommend splinting of some kind, especially if they were a stroke patient. I do think this functional electrical stim, from what I've read, seems to be the most promising of some of the newer things I've read about that, on top of this TMS as well, seems to be something that I think is worth studying further. But I don't know if we're at the point where I would be routinely recommending patients to kind of seek that out. I think generally speaking, a combination of stretching, splinting, in combination with oral medications, and just PT and OT are probably the most important things right now, and using them in combination, I think, is best for the patient.
Yeah, I think I agree. I think if you're a new spinal cord injury patient, you do want them to stretch, even though for something that we use so ubiquitously, the evidence is extremely poor. That's something that we've been doing for a very long time, but does stretching help? It seems to be. I think there's enough evidence that it doesn't hurt, particularly in stroke. I think the evidence really, like slow passive stretching, leans more into doing it than not doing it, although it's certainly not, well proven by any means. So I think discussing stretching and doing stretching early on is certainly appropriate. I think passive, slow stretches, the longer duration is usually the way I would recommend it, based on the kind of weak literature that's out there. Obviously, if it's beyond just not talking about medications. Again, you don't want to be too aggressive. Things like tenodesis grip can be really affected if you overstretch them. So you want to keep that in mind for especially somebody with tetraplegia. And then if they start to develop spasticity, again, medication, stretching, I think are all beneficial. But I think adding NMES, FES is certainly appropriate for many of these patients as well. And I think the benefits likely outweigh the risks with those types of interventions. So no, I think that was a really great overview. I think there's definitely more research that's needed in this area, particularly well done controlled trials, because we do a lot in rehab, but we don't really know if some of it works. So thanks, Peter. As always, these lectures will be available on the YouTube channel for review later if anybody is interested. Thanks, everybody. Bye.
Thank you.